aches, pains, questions about anything to do with your health, that's what we are covering each and every show here. And if if you're a little bashful, you don't want to get on the air, you can always contact Dr. Lou after the show anyway. He mentioned the number there, or info@paincarecanada.com. You want to toss him an email and have a chat, and not on the air, but we'd love to get you calling in this afternoon. Lots of stuff to get through, as we do every show, Doctor. But first, we start with the week that was, yeah?
Yeah, for sure. As you mentioned, last week we had a ton of calls come through the lines, and I even stayed back a little bit after the show and took some more calls. And during the week, actually, a lot of people followed up with us. And one of the things that I really wanted to highlight, more from a general perspective, is that we offer these free consultations, and I've been able to have free consultations with people calling in and just getting some advice. And yeah, some people have turned into patients that have actually gone to one of our clinics, and then other people, it's just a simple piece of advice and they're on their way and they get better. And we've been following up with people so that way we can determine, are things actually getting better? Are you getting the care that you need? Because that's the whole point of what I want to do, is be able to actually help people. So I'm here to, once again, highlight the fact that I'm available throughout the week at the 1-855-55-Dr. Lou number. People can give me a call. I'll get back to them within 24 hours. We can have a quick discussion. Even if they want to come into my clinic, book an appointment with me. A free consultation takes about 15 minutes. And I mean, the worst thing that you're going to get is some good advice, is the way I look at it. So that's a good thing.
So what cool stuff happened this week?
One of the bigger things that I've been noticing a lot, and I seem to notice this in practice when the weather tends to change, and we've discussed this before, is referral patterns. So a lot of people coming in with pain in a certain area, not necessarily being caused by that area. So the example could be, I had a patient this week who had pain in their upper right shoulder. And again, the referral pattern of the diaphragm lower down. So when you're not able to really understand referral patterns, and oftentimes these people are getting treated at the area of the symptom, which is not a bad idea to start when you actually think about it. But this is where an educated professional who understands the body very well can look at it and say, okay, what could be the potential causes creating this symptom that I'm seeing? And yes, it's important to consider that it could be that same area. It could have been the right shoulder. But then as you go through it and you start to determine, okay, the right shoulder seems fine. So where else can pain come from to the right shoulder? And that's when understanding referral patterns, like from the diaphragm or the gallbladder, and you start to look at these other things where you're like, okay, well, let's make sure it's not a gallbladder issue or a liver issue, and let's treat the diaphragm. And people are getting better and these referral patterns can go a very long way. I actually had another patient who was complaining of pain at the side of her knee on the left side. And it ended up being a trigger point in her quadratus lumborum, which is a muscle in the low back that also attaches to the psoas, which is a hip flexor. And so we treated that area of her body, and it got that knee referral pattern totally better. I didn't even work on her knee. So it was really important to distinguish that. I could tell by her symptoms as she was describing it to me that it didn't seem like a knee issue. It really seemed like it was an issue coming from elsewhere. And so, again, understanding referral patterns, I was able to understand quadratus lumborum, psoas, have that typical referral pattern. You go in, and it's very simple to test for this stuff. You poke on that muscle, and if the patient's complaint intensifies in that area, then you're dealing with a referral pattern. Then you treat that, and I was able to treat that with acupuncture and some active release therapies, and patient got 100% better. She's very active, so these are things that do tend to be more common in active individuals.
It's pretty wild that the start of the journey can be here, but then the end point's a completely different part of the body as far as pain's concerned.
Yeah, and I've talked about this a lot, and most people kind of understand this, but the body's all related. You can't look at the foot and say that that's different from the knee, that's different from the hip. There's a constant link between everything. In fact, there's something called fascial links, which are ways that fascia is a covering of the muscle. And yes, there's individual muscles, but fascia tends to overlap into different areas, and it kind of creates a fascial network throughout the body. So you can track actually some fascial links all the way from the neck down to the feet. So that shows you that it's clearly related.
It's like when your kids, the knee bone's connected to the, that whole thing, right?
That's
Same type of thing.
True.
416-870-6400, star 640 on cell is the number. Wide open lines. Lou, good afternoon. How are you?
Hey, good. How are you guys?
Good, pal. What's going on?
Good. Okay. It's a nagging, like a dull ache, the upper left side of the back, almost underneath the shoulder blade.
Okay.
I went to get x-rays from the family doctor, and his broad explanation was his arthritis, and there's nothing he can do. I got my chiropractor to kind of read the X-ray results, and he really explained it. He said there's a bit of maybe of degeneration in the disc. But anyways, is there anything I could do just for the daily? Like, I don't want to pop pills every day and just to kind of numb it. Other than mobility or anything like that, like, is there anything that you could suggest?
Yeah, I mean, the bigger thing comes down to, and this is kind of an excuse that's often used by professionals, is they'll take an X-ray or some type of imaging and they'll use the findings on imaging to explain the person's symptoms. And those two things don't always correlate. So there's actually good evidence looking at X-rays for the low back. And what the basic finding is that it's a 50-50 correlation. So if we took 100 people and we X-rayed their backs, 50% of those people would have some type of degenerative change just because that's aging of the skeleton. It's gray hair of the skeleton. Not the same 50 people would necessarily have pain. So when you look at imaging, there needs to be a correlation between what you see on the image and what the person's complaint is. And so when I hear Lou saying something like this, where the pain is kind of in the left side of the back, just below the shoulder blade, that's not really where you would necessarily expect something like a degenerative type of pain to cause any type of symptom. And this could be a good case. And again, I can't be 100% sure because Lou's not here in front of me. I can't examine him. But this could be a good case of a referral pattern. Sometimes referral patterns actually lower down in the back can cause referral patterns up higher in the back, similar to what he's describing, or even somewhere in the neck. We talked about this last week with the long thoracic nerve that comes down that way along the scapula, that there's an issue that could be caused. And if it's created in the neck, you might be feeling pain in the shoulder blade, but not necessarily created at the shoulder blade. So Lou, this is a good example of my free consultation. Give me a call. We can actually discuss this a little bit further so that we can really divulge into what it is and try to figure it out. And then I can make a better recommendation in terms of what are the things day to day that you can do. Because again, over the air like this, I can't be 100% sure that
I know. I find doing a bit of they suggested to do some lightweight work does help, but it's very it helps maybe for that day, maybe a day and a half, and then it kind of creeps back.
Do you find that your pain is better once you get going and moving around?
Yeah, if I'm moving around, it's way less.
Okay. And that usually, when people describe that type of response to movement, it usually indicates a muscular issue. So this is a good example that it may not necessarily be a bone. And what ends up happening with muscles is when they're tense, they tend to create pain. But as you get moving around, they loosen up and they get better. And that's very characteristic of muscle complaints, is that it's better once people get going.
Go to info@paincarecanada.com as well if you want to email Dr. Lou here. You know, the last call Lou was talking about, and you talked a little more about that pain, the referral pain, and what it could be, right?
Yeah. Another aspect of Lou's call that I found very interesting was the part where he said that he's been recommended to do exercises and he'll do those things, and it does tend to feel better. One of the hardest things that I think myself and most people dealing with pain face is that people assume that pain is something that you have and you should be able to get rid of instantaneously. It's much easier to accept in health that, you know, for example, if you get diagnosed with diabetes, that's something that you have to manage for the rest of your life. Not too many people wake up and say, you know, well, I take my metformin and it seems to be great, but if I don't take it, it's not so great. That's kind of the reality. That's why the medication exists. The unfortunate reality, and I hate to break the news to everybody, but pain and most injuries function the same way, especially as we get older, and those things that have happened previously tend to come back and haunt us. The reality is that a lot of these things are management issues. So it's never, you know, and this is where you have to speak with someone and understand their clinical case. But oftentimes you're never looking to get 100% better without any exacerbation of that pain. Because the reality is, the research supports that if you hurt an area of your body once, you're likely to hurt it again. And the more times you hurt it, the more likely it is to get worse as you continue to hurt it. So your body now has a weak point and you have to do these things. So when Lou was talking about, I do my exercises, but it's only good for a few days, that sometimes is the reality. Sometimes you have to keep up with those exercises. That exercise is equivalent to that metformin for your diabetes. You got to do it in order to stay healthy. There's very few times, and it's actually consistent around most of healthcare, that there's ever a true cure in which that you can do something, it eliminates the problem, and it never comes back again. The reality of healthcare is most of healthcare, including pain management, is management. The word is in the term, pain management. We manage people's pain. It's
amazing, and it goes back to something you said way back in the first show we ever did, that mobility, for the most part, is better than immobility. Keep the body moving. Right?
Absolutely.
Posture is having no posture.
Yeah, I'm a big proponent of that. We have a corporate wellness division where we also go into a lot of different workplaces, and we do things from lunch and learns all the way to ergonomic assessments. And my ergonomic assessment is always, you got to get up and move. I'll look at people's desks. I'll definitely make recommendations on where they could be more optimal. But my biggest recommendation, where I really try to hit home with people and make them understand that the only way for you to really eliminate an issue is you got to get moving every 20 minutes. Every 20 minutes, you have to change what you're doing, because we are dynamic creatures. That's what we were designed for. Nice. You have to be able to move around.
416-870-6400, star 640 on cell is the number. Something you also said I thought was really interesting in the first segment we just got on here today was you can look at diagnostic imaging and x-ray, and then you look at pain, and they're not always cohesive. Have you ever come across, say an x-ray and MRI saying, man, this guy, I look at this guy should be in tons of pain, but he's not. How do you figure out the problem?
Yeah, no, there's been tons of times. There's been times actually where I'm confident that I'm going to send someone for some type of imaging and I'm going to see something. And then, the low back, I'm thinking, okay, this person's got to be riddled with degenerative changes, and I'll send them for an x-ray. I can remember a 60-year-old man once that was complaining of really bad low back pain. And I'm thinking, okay, 60 years old, it's not going to be unlikely that there's some, and again, degeneration is normal, but it's normal to a certain extent. That's why it's graded in different ways. And I'm thinking for sure we're going to see a lot of degenerative changes here. Sure enough, goes for the x-ray, comes back, looks like he's 20 years old if you looked at his x-ray. His x-ray looked better than my x-rays of my low back, but yet he's got more pain than I do. And so, it tends to happen both ways, even the other way, like you mentioned, where you look at somebody's x-ray and you think, oh, wow. And a lot of the times you're not really sending for x-ray if there's not an indication, but sometimes we'll send people, say, for a hip x-ray, and you get a portion of the low back in it. And you'll notice the low back and you think, wow, that low back looks really bad in terms of degenerative changes. Meanwhile, they're here talking to us about, hip pain. Right. And so you're thinking, I'm surprised that his low back is what's not bothering him. But that's the reality, that clinicians, this is the what I always talk about. Clinical acumen is the word that I use. This acumen is the ability for a clinician to use all the tools and come to a cohesive picture together. So yes, imaging could be important, blood work could be important, but you have to look at all those things in relation to the patient. That's why radiologists send back their results to the family doctor or to whomever referred for it, because they don't have the full clinical picture. They're given one quick sentence, trauma to the low back. That's all that they know. They're not making the final diagnosis. That's why they send it back, because they understand this needs to be related back to the clinical picture.
416-870-6400, star 640 on cell. Good afternoon, Joe. How are you?
Good, gentlemen. How are you?
What is going on with you?
Well, 3 months ago, I was diagnosed, I guess, with tennis elbow. I'm not exactly aware how I got it or what I did to actually strain it. Now, it's on my right side, and I'm obviously right-hand dominant. Now, the initial course of therapy I was given was an anti-inflammatory plus physio. But it's still, I don't feel that it's always 100%, especially when I make a fist. And now when I just touch actually the bone part of my elbow, it feels like there's actual trauma to the bone when there's no trauma to the best of my knowledge. So I guess my main question is this something that I'm going to have to deal with for, I guess for the rest of my life per se? Or can I expect to get, a better course of therapy that will make it, I guess, permanently go away? I'm 42 years old, so I guess I'm not as young as I'd like to say. So I just wanted to get your input on that.
Yeah, for sure. We've actually had a few calls, and I believe we had a similar call last week about tennis elbow, and I went into some detail about the actual pathology of what happens with tennis elbow. And the medical term is epicondylitis. And so if it's medial, it's called golfer's elbow, and if it's lateral, it's called tennis elbow. And so these are just the layman's terms for it. But epicondylitis suggests that at the epicondyle, which is a piece of the bone, there's inflammation. And that used to be the thinking about this pathology for a very long time. That's why Joe was prescribed anti-inflammatories. The unfortunate part about why it's still lingering is because the most up-to-date research actually looks at this from a microscopic level and determines there's no real inflammation actually going on. What you actually have is an epicondylosis, and that term osis just means pain. And so what's happening with the epicondylosis is there's no actual inflammation going on, but that bone, that muscle to tendon to bone transition that happens on a histological level, what happens is there starts to be changes in the actual histology, the actual cell makeup. And so where there should be probably more tendon type of cells, you would find more bone types of cells. Right. And that's where he's describing it starts to feel like there's trauma in that area, is because it's actually changing. What needs to happen in those situations is you need somebody to actually create micro trauma to break that area up again, almost creating the injury again in order for it to heal properly. So I would say, Joe, give us a call. It's not the end of the line, and that is actually something that could be helped with if it's treated right with that type of approach.
Back we go to Chris. Hi, Chris.
Hello, how are you?
Good, sir. What's going on?
Well, I've got pain in my left knee, and it's been there for about probably the past almost a year now.
Okay.
And it's quite painful.
Okay. Have you done anything else? Like, have you had it checked out at all, Chris?
Well, I'm in the process of looking for another doctor because mine had a heart attack, and he's taken less clients now. So so I'm looking. I've gone through Service Ontario to find another doctor.
Okay. How old are you, Chris?
I'm 56.
Okay. And where exactly in the knee does it hurt? Can you try to be specific? Like, is it around the kneecap? Is it above the kneecap? Behind the knee?
It's behind the knee.
Behind the knee. Okay. Any swelling or bruising that's ever visible?
Yes.
Yeah. Okay. So one of the things anytime you hear something like swelling, your first thought, and especially in someone of Chris's age, see, the one thing where imaging does matter with degenerative changes, the one place that's very unique in the body is actually the knee. So as the knee starts to degenerate and you start to lose that disc space, what ends up happening is that the synovial fluid inside the disc can sometimes start to leak out. So that usually indicates that there's an internal problem, some type of what we would call internal derangement of the knee, whether it could be the meniscus or whether that's a tear or just an inflammation of the meniscus. But definitely based on what I'm hearing, Chris, the first thing, and that's on what I'm hearing in a limited fashion, I would already start to think meniscus. When I hear the back of the knee, the other thing you can start to think of is Baker cysts. So these are cysts that are formed by that fluid that actually leak out, and they create a little bit of a cyst, and that will create pain. And those cysts can actually be worked on by some type of a therapist. Doesn't necessarily need to be surgery in order to get rid of them. And the other thing that's often forgotten about the knee is there's this one muscle in the back of the knee called the popliteus, which is the locking muscle of the knee. So when you stand up straight, your knee locks. It's that muscle that causes that. It's one of the most important muscles of the knee, and it often can go into spasm. So that could be another cause of the pain. So I'm either thinking could be something like a meniscus issue, could be something like a Baker cyst, or could be a popliteus syndrome is what we would call it. But Chris, I definitely think that when you're dealing with something like that, the reality is going to your family doctor is probably, and this is a big, actually in a few weeks, we're going to have an MPP from Queen's Park on, who's the conservative health critic, and he's also a pharmacist. And one of the things that when I was at Queen's Park last week talking to some of the MPPs was having people educated on what they can actually do that would increase their plan of management and increase the likelihood that they get better. So I know you've been waiting for your family doctor, Chris. In all likelihood, that family doctor is probably just going to send you for an x-ray, not going to come up with much information. This is where someone like a chiropractor is probably better suited, or a physiotherapist, someone who has specific knowledge in the anatomy of the body and can make that diagnosis without having to go around all that other stuff and get you the treatment that you need right away. And that's, again, give us a call at the 1-855-55-Dr. Lou number. We can definitely help set you up with someone who can take a look at this and definitely get it treated, because it doesn't sound like you've had any treatment. And already when I hear that, having any treatment is going to make a big difference for sure.
Well, I thank you very much. And I'll look into that. Okay. And I'll certainly keep all that in mind.
Okay, great. Awesome.
Chris, at number 1-855-55-Dr. Lou, and we'll get to another one here before our break. Yvette, hello.
Hi, how are you?
Good, excellent. How are you? You got a question or concern for Dr. Lou?
Well, I do actually.
Okay.
I suffer from degenerative disc disease at the upper region,
Okay.
and I've also got fibromyalgia and severe osteoarthritis in my lower back.
Okay.
I'm finding that it's getting more and more difficult for me to stand for more than about 5 minutes
Okay.
without my back getting extremely weak.
Hmm.
And even walking is the same thing. Sometimes it seems like it travels to the actual hip joints.
Okay.
Where the legs almost don't feel like they're attached.
Yeah, it's a weird feeling.
You understand what I'm trying to say? They're sore.
Mm-hmm.
I take Advil, I take Tylenol. None of it really helps.
Okay. How long ago were you diagnosed with the fibromyalgia?
2000.
Oh, we lost her.
Oh.
I didn't hang up on her. She call us back, Yvette, if you can. We'll take a quick break. Hopefully, you can call us back again. Pain concerns, something long term, short term. Just discovered it. Need diagnosis. Want more information on the fly? Yvette, look at you. You got through again. Love it. How are you?
Oh, great again. Thank you.
So as we were, and we're back. Continuing. Where what were you going to say?
I was asking Yvette when she was diagnosed with the fibromyalgia, and I heard 2000 and then it died.
2004.
2004.
Oh, okay.
Anything leading up to that? Any type of trauma? Anything more that you can tell me around that diagnosis of fibromyalgia?
I'd been in a car accident
Okay.
in the year 2000.
Okay. Yes.
And suffered severe back injuries in the thoracic, the lumbar, and the cervical.
Okay. And I'm assuming you've had a lot of treatment throughout the last decade.
Yeah, they gave me a lot, but none of it ever seemed to help.
Okay. Yeah. Well, and we touched on this as well last week about fibromyalgia, and it's kind of, unfortunately, a wastebasket term that the medical profession that we tend to use when we look at a patient, and in the absence of anything else, like something that's autoimmune in nature or anything neurological in nature, we have this term called fibromyalgia, and we've made a diagnosis out of it. And we won't get into the politics of why we make things diagnoses, but fibromyalgia just means pain in the fibers and muscles of the body. That's all it means. And so really what it is it's chronic pain related to the body in every single place. And it's not uncommon to hear patients such as yourself, Yvette, that have fibromyalgia and have the widespread chronic pain and tend to have pain all over their body. The biggest thing that I can tell you when it comes to fibromyalgia, and when you've exhausted all the options from a physical perspective and from a medical perspective, and we've touched on this before, is touching on the psychological aspect. Because again, going back to the psychological interpretation of pain and its creation in the body, if you don't target that aspect of what's going on, it's very hard to ever get better in cases like chronic pain or fibromyalgia. Have you done any type of psychological intervention related to pain management, Yvette?
I have done that in the past, and again, got absolutely nowhere.
How long did you do it for?
About a year, almost.
Yeah. See, the one thing with this type of stuff is when I talk to people, when I see chronic pain patients, and I try to tell them, you have to do everything right at the same time. That's the hard thing about chronic pain is you have to be doing therapy. You have to be doing cognitive behavior therapy. You have to be eating right. You have to be exercising. There's so much involved because it's so complex, it therefore needs a very complex answer in order to get it better. Yvette, it's a complicated issue. It's definitely something that I have a lot of knowledge about, and I have a team in place that can definitely help. So again, give me a call for that free consultation where we can actually talk about this a little further, and I can get to understand it a little bit better and go a little more in depth into the history of the complaint so that I can give you some better recommendations.
Okay, that would be awesome.
Okay.
Yvette, really appreciate you calling back. Have a fantastic day. 416-870-6400, star 640 on cell. Got some open lines happening. John, welcome to the show. How are you?
I'm pretty good. Yourself?
Good. What's your concern?
I herniated my L5 and S1 disc when I was 15, which was great.
How old are you now, John?
I'm 26.
Okay.
It never fully healed. The doctors my doctor originally, didn't, for about 6 months, didn't pay much attention to it. He thought I was just trying to get pills out of him. Ended up in the hospital because my leg ended up going numb, was off work for quite a long time. It's been a constant kind of up and down struggle. It's never fully gotten better. And I'm just wondering, aside from core strengthening, massage therapy, NSAIDs, is there anything that I can do long term to try and to minimize the pain and the damage? I'm in a pretty physical line of work,
Okay.
so it's not like I'm helping myself in that regard.
Right. It's actually interesting that you bring this up, because I had a patient this week with almost a very, very similar history to yourself. One of the things with disc herniations is the body will tend to break down. So something like a disc herniation happens at a weak point. And going back to what we talked about at the beginning of the show with fascial links, one of the keys when I look at people that have had a breakdown in a certain area that I guess I've failed to mention thus far since we've been doing the show is something that I do call the functional assessment. So this person that I had a disc herniation on the left side, and was causing the typical disc herniation symptoms of the sciatica down the leg. One of the things that I was able to identify when I started looking at the fascial link, because I started thinking, well, why did that area break down? Why did the injury happen there? So I started looking into a gait analysis and looking at his hip and his ankle range of motion and movement. And I was able to find that actually the majority of his problem was coming from his hip. So basically what we did, and he had been seeing other people who had been treating the disc herniation, going back to you treat what you think is the problem.
Squarely on the back.
I have focused all my treatment on his hip, and he's been living with this problem for, I believe it was about 2 years, and wasn't getting any real improvement with the typical type of treatment for disc herniations. He wasn't, in any exacerbated state, so at least he was able to function, but he had that chronic low-level ache that he couldn't get rid of, and I have focused my treatment solely on treating his hip, and he's already improved by 80%, and his pain's almost gone. So for someone like you, John, and the reason why I thought about it was also because of the age. When it happens at 15, when something happens that young, it really tells you that there's an area of stress in your body that's not being identified, because you would think it would be more common to see it later on in life, but once you start seeing it that early, it really identifies that there must be something functional going on that's really creating an area of weakness in the body. And so assessing the function of other related parts, and it may be the hip, it may be the knee, it may be the ankle, it may be the upper back, it usually will start lower down. It usually doesn't tend to be higher up. So I'm thinking something like the hip or ankle, but definitely getting those things assessed. And if you give us a call, you come in for that consultation, we can actually do that and determine, okay, this may be something, coming from your hip or from your ankle, and we treat those things, and it may give you the improvement that you've failed to have, I guess, in the last decade.
Okay. Yeah, definitely.
Okay, John, thanks.
John, that number is 1-855-55 Dr. Lou. You need to email, get some more information, info@paincarecanada.com. Let's talk about a little bit, because it's come up, 3 or 4 phone calls so far, and you and I were just chatting about it before the mics went on, and that is common causes of low back pain, because that's a big bowl of fun right there.
Yeah, for sure. Low back pain, every time I explain it, it's funny when I have patients that come in and say, I was at my family doctor, or I was somewhere else, and they told me that I have low back pain. Mm-hmm. It's like, okay, that's great. That's a symptom. That's the equivalent of someone telling you have a fever. Now you have to determine what's causing the fever. So when you look at low back pain, it falls on a spectrum. And the way I always look at the spectrum is you're looking at the very benign treatable issues, like if it's a muscle or a joint, all the way to the very malignant and potentially life-threatening things like a tumor or whatever. And obviously those more serious things are very, very rare. And much more common are the benign side of the spectrum. But there's so many different things that can cause low back pain that's why you need someone who actually understands the low back pain. When they've done research on this, they actually find that family doctors, and next week we'll actually have a surgeon on the show, and he'll speak to this as well about the lack of training that family doctors have in this, and they realize it themselves. That's why they refer to other people. They realize the limited knowledge that they have on such a complicated area. When you actually look at it, the back, I would argue, is as complicated as the mouth, and we have a whole separate profession dedicated to that called dentistry. Right. So, and I know chiropractic is really trying to move towards spinal healthcare experts. I know at the chiropractic college where I teach, that's where we want to go in the future, to be the dentist of the low back and the neck and really help with all those spinal complaints. But the reality is you need someone who can look at it, understand all the potential causes of the pain, and determine, okay, where on this spectrum is this person falling? And then the type of treatment that falls into to the pathology really depends on what the problem is. Obviously, if you have someone who has a tumor, well, they're going to go for surgery, get it removed, and go through that route, versus if it's on the benign side, oftentimes the person who's assessing you properly can also treat you on that side.
Do you find percentage-wise low back pain is a little more common than upper back pain?
Yep, for sure. Low back pain is probably the most common, followed by neck pain, followed by mid back pain. And it's very simple when you actually understand, when you actually look at anatomy, why that's the case.
This I find, never thought about it.
Yeah, so the reason why is two things in the low back where it's very common is if we stripped away your body and we looked at the skeleton, it's actually, there's nothing there except the spine. So you have the rib cage and then you have the hips. So it's just an area holding it up. Yeah. Plus you have all the weight of the upper body falling on top of that area. So that's why it's very common to have injuries. And that's why it's second most common in the neck, because again, the neck is very similar to the low back. There's nothing there except muscles and the
big head.
But the head is much lighter than the whole body. And mid-back problems tend to be the less common because of the rib cages there. So it creates an inherent type of structural stability that's not common in the neck and in the low back. So low back, neck, mid-back is usually, and low back is not just the most common in terms of the spinal-related complaints. I believe it's the third most common pathology that people experience in their lives. I think only next to the common cold. It might be 2 or 3. I can't remember the exact stats. I know for time missed off work, it's second to the cold. So when employers look at why people miss time from work, it's often low back pain, only second to the common cold.
416-870-6400 star 640 on cell. Newly, how are you?
Not too bad. How are you doing, gentlemen?
Let me guess. Back pain.
Yeah.
How about that?
See, I told you it was second most common.
Right?
I feel like everybody else then.
Yeah. Tell us more.
I have an upper back problem.
Oh.
It's probably right where my diaphragm is if you drew kind of a straight line.
Okay.
And if you run your fingers down my spine on the left side and on the right side, on the left side there's a lump on one of the vertebrae.
On the left side. Okay.
And it's not soft, it's hard, but when the pain starts, it kind of takes your breath away.
Okay.
I talked to my doctor about it, and he basically said it's probably a cyst, and nobody's going to do anything about it.
Okay. Yeah. I mean, the reality is, number one, when he says it's probably a cyst, in order to really determine that, you have to kind of get some type of imaging, some type of an ultrasound to actually look at if it's a cyst, right? Anytime you see one side where there's a lump, you start to consider a few different things. Like you just mentioned, could be something, a growth of some type like a cyst. One of the other things that can cause humping on one side is scoliosis. What happens in the back, scoliosis is a bend in the spine. There's something in the back, it's called a coupling motion. So when you develop some type of a bend, there's a lateral bend component and also a rotation component. And when that vertebrae rotates, the TVP, which is one of the bones on the side, actually starts to hump towards the skin. And so people will feel that and think that they have a growth, but all it really is a mild scoliosis causing a little bit of rotation of the spine, causing that bony part of the vertebrae to be more prominent. Yeah, Newly, definitely that might be worth the consultation in the office. No charge. You come in, we take a look at it. I can definitely give you a better idea. And you know what? If it is a cyst, although your family doctor thinks no one will do anything about it, people on my team, if the way surgeons will look at this stuff is if it's not causing a problem, we're going to leave it. If it is causing a problem and it's causing you pain, well, then that's a different story.
We'll go further, maybe.
Yeah, then it's a matter of assessing it and determining. Anytime you go into something like surgery, and again, we'll have a surgeon on next week who will talk about this stuff, but risk versus benefit. Yeah. So if the risk is very little, but the benefit is going to be great in terms of eliminating potentially your pain, then it might be worth it. If it's not, then, that's a conversation to be had and to be determined.
Newly, it is 1-855-55 Dr. Lou, DRLOU. Very simple number to call, 1-855-55 Dr. Lou, and we'll get to Mark here before the break. Hey, Mark.
Hi, how you doing, guys?
Good. What's happening?
I just wanted to get your take on inversion tables since you're talking about backs. I've got kind of, off and on lower back stiffness, soreness, and I just got one a couple days ago. Tried it out, and actually the second time I was on it, it felt like I was opening a can of beer or something. Just a pop and a fizz, and I feel a lot better.
Yeah. Okay, so it's a complicated answer with inversion tables. for some people it's great, and for some people it's not great. So it really, see, the problem with all of these home care devices is that people then become their own doctors, and that means they start to prescribe their own dosage of how much they should be doing something. And that's the reality with over-the-counter medication as much as it is with inversion tables. That's where problems get created, when people don't actually understand dose and response of things. And so, yes, inversion tables can be very beneficial, but I think they're much more beneficial when its recommendation is from a professional that actually gives you an outline on how you should be using it. Because the reality is, people such as yourself get one, they use it, it's totally new. Most things that are new to the body will feel good in the beginning. That's just the reality. We've talked about adaptation. So it'll tend to feel good. And because it feels good, you'll start to do it more and more often. And as you do it more and more often, that adaptation starts to take into an effect. And then what ends up happening is you end up hurting yourself more than you were prior to having that inversion table. So it's not necessarily that the inversion table itself is bad, but sometimes its overuse by someone who has very little knowledge about its actual indication is what creates the problem. So, and I'm not suggesting that that's you, Mark. You may have done all your research and you may have gotten the right advice, but that's my opinion on most home care devices such as inversion tables, is that there needs to be proper dose response management on that. And oftentimes the general public doesn't know what that is.
Frank, good afternoon, Frank.
Good afternoon. How you guys doing?
Good. What's going on?
Well, back in 2004, I ended up having to have, 2009, I had to have knee replacement surgery. A couple of years ago, got major infection in the knee, and they had to do a multi-stage revision and then go back in and change the liner.
Wow.
And I've got maybe about 10 to 15% range of motion with it, so I'm trying to figure out what to do there. But I'm also in chronic pain with it. I've been through lidocaine infusions, with the ketamine and stuff like that, through pain clinics and Tylenol 3s and everything else. And I'm a professional driver, and I'm just at my wit's end with trying to deal with the pain aspect of it.
Yeah, Frank, that's a heck of a type of a scenario. It's obviously very rare, but unfortunately it did happen to you, and obviously, your outcome now is very poor in terms of what you've been suffering with. The reality is, something that's that complicated probably needs a little bit more attention paid to it in terms of actually speaking to me personally and getting a little bit of information about it. One of the things that I can tell you is that the orthopedic surgeon that's on next week primarily does knee surgery. So he may be a good person to listen to that show and get some information around that. But definitely the complicating issue of the infection and then having to have it revised, and then, the limited function that exists after it. One of the things, I don't know how much therapy you've done, and it may be worth a shot, but when you look at the knee, there's a lot of things that attach to the knee, including, the quad, the hamstrings, and also the calf muscles. So sometimes working on those more distal aspects of the knee can have a tremendous effect on the actual function of the knee itself. So in the absence of, being able to do anything for that knee, you may want to get someone to look at the upper leg and the lower leg and the surrounding muscles, and maybe trying to do some therapy around those things.
Yeah, after I had the revision surgery done, I went through like about 6 to 8 months intensive therapy on it, and I still don't have any of the range of motion. I'm now looking at, I'm going to have to get a special shoe made for the left because my heel's about 3 to 6 inches off the ground.
Oh, wow.
So I can't even stand straight. I can't do anything. So I'm looking to go get a third opinion to see what they can do to try and break up the scar.
Well, you know what, Frank, that you can also get a fourth opinion with me through that consultation, right? It's going to be worth it. Again, it's very complicated. I'm interested in actually seeing it to understand exactly what you're talking about.
I left my name, my phone number with your screener.
We got it.
Yeah. Okay. Awesome.
Yeah.
So
I'd love to get in touch with you. And
I'll follow up with you this week personally, and we'll try to get you in and have a look at it for sure.
And just in the meantime, if you lose it, Frank, 1-855-55 Dr. Lou is the number. I wonder if a matter of time when something like that, now the other knee's going to start bugging him because he favors it, right? That's common, right?
Compensation of the other side of the body is a big deal when you look at injuries, because oftentimes, and I see it all the time, it's it makes it harder to treat people because people are coming in and they have right shoulder pain, whether it's, frozen shoulder or something, or they have a right knee complaint. And then you're treating that area and it's getting better. And they'll come back and they'll say, yeah, you know what? That's getting better. But my other side is starting to bug me. And it's a compensation, right? If you can't use your left shoulder, you therefore have to use your right shoulder. And if it's uncomfortable to put a lot of weight on your right knee, you'll start to, move a lot of that weight towards the left knee. And so compensation pain is a big deal. And any good practitioner is going to make advice on trying to minimize that effect. I know with my patients at our clinics and my whole staff, we try to make those recommendations in terms of what can you do to avoid this going to other parts of the body, and also treating it if it does start to occur. You should never have someone tell you, well, that's a separate issue and we'll deal with that when this gets better. No, it's not a separate issue, and it should be dealt with as it's happening. It's fun being a bipedal life form, isn't it? Stand up on two legs. Good times. Yeah, for sure. We'll take it for another week. In the meantime, this is a number you should have it at you all times. 1-855-55-Dr. Lou. 1-855-55-DRLOU. And info@paincarecanada.com. We are back next weekend.